Let's discuss some explain why questions from the chapter drugs affecting blood and blood formation. So the first question is ionized salts of iron for oral route cannot be used parenterally. So we know there are two forms of iron, like for the use orally use for oral use and for parenteral use, IV. Uh, like for an example, for oral use, we use like ferrous fumarate, ferrous sulfate, and for parenteral use, there are iron dextran, iron sorbitol citrate. These are the few examples. So the question here asks that why, like for example, ferrous sulfate cannot be used IV. Why it can only be used oral as an oral tablet? So the answer is oral iron preparations are simple ionized salts. If these ionized salts are injected directly into the blood or muscle, they immediately release massive amounts of free elemental iron. This free iron in the systemic circulation is highly toxic. It precipitates proteins, destroys tissues, causes fatal cardiovascular collapse. So that's why ionized salts of iron, that means the oral iron preparations, cannot be used parenterally. A few examples of what's special about those parenteral iron preparations. In parenteral iron preparations, there is a carbohydrate shell which prevents the release of free iron. It releases gradually. It releases controlled. There is a controlled release via the reticular endocellular system in case of parenteral iron preparations. So let's move to the next question. Intravenous iron dextran is prohibited and not used now. Intravenous iron dextran is prohibited and not used now. So the answer is intravenous iron dextran has a very high molecular weight, which is very antigenic, which is highly antigenic, and it triggers severe anaphylaxis or shock. That's why it is prohibited. So what is used in case of the iron dextran? Like iron sucrose, iron sorbitol citrate. These preparations, ferric carboxymaltose. These preparations are used instead of iron dextran. Then British anti-leucite is contraindicated for the acute iron poisoning cases. So British anti-leucite is a chelating agent used for heavy metal poisoning like arsenic or mercury, but it is strictly contraindicated for iron. Why is that? In case of in case of iron poisoning, dimercaprol or British anti-leucite, if given, it forms a complex with iron. This complex is highly toxic to kidneys or systemic circulation. That's why it's contraindicated. So what is used instead? In case of iron poisoning, the antidote is desvelioxamine. It is used, not British anti-leucite. Then question number 4: vitamin B12 in urine suggests exceeding dosage. In case of overdose of vitamin B12, normally, let's talk about normal. Normally, vitamin B12 in the blood binds to a specific transport protein, that is transcobalamin 2. But this transcobalamin 2 is limited in our body. So if there is an overdose, there will be a saturation of transcobalamin 2 will be 100% saturated. Then the excess vitamin B12 remains unbound or free in the plasma, that is rapidly filtered by glomerulus and excreted in urine. That is wastage of drug. So that's why vitamin B12 in urine suggests exceeding dosage. Then question number 5: hydroxycobalamin is preferred for parenteral use over cyanocobalamin. The very short answer for this question is hydroxycobalamin is hydroxycobalamin is longer acting than cyanocobalamin, so it requires less frequent intravenous injections. This is the main reason. And why is that so? Because it is highly protein bound in plasma. That's why it remains in the blood for longer time, and its excretion is very slow. Then question number 6: oral vitamin B12 preparations are not suitable for pernicious anemia. So you have to know the pathology of pernicious anemia. What happens in pernicious anemia? And pernicious anemia is an autoimmune disorder in which autoantibodies are formed against the parietal cells, which leads to its destruction of parietal cells, and that causes and the intrinsic factor is decreased. So there is complete absence of intrinsic factor. There are pernicious anemia is of several types, but let's not discuss about that. Complete absence of intrinsic factor. So oral vitamin, but you have to know the vitamin B12 absorption pathway as well. So this, in very short, oral vitamin B12 preparation. Oral vitamin B12. This vitamin B12 for its absorption needs this intrinsic factor. But in case of pernicious anemia, there is no intrusive factor, so oral vitamin B12 cannot be absorbed. It will be simply just excreted in the feces. So you must use parenteral route instead. That is intramuscular. So this question can be asked like this as well. That intramuscular vitamin B12 is used in pernicious anemia. Why? So let's move to the next question. Question number 7. Folic acid should never be given alone in vitamin B12 deficiency. So in case of vitamin B12 deficiency, we know that there is megaloblastic anemia, and there could be subacute combined degeneration of the spinal cord. That's neurological damage. If folic acid is administered alone, it corrects the DNA synthesis block in the bone marrow, but it cannot correct the underlying vitamin B12 deficiency. That is masked, because we will think that the megaloblastic anemia has gone. It has been corrected. So that picture looks normal, but the underlying vitamin B12 deficiency is masked. That leads to neurological lesions progression of the neurological lesions, and it can become irreversible. That's why it is not given alone. It is given along with vitamin B12 in vitamin B12 deficiency. So let's move to the next question. For question number 8. Folinic acid is now routinely infused IV along with 5-fluorouracil. So 5-fluorouracil, when administered, it's 5-fluorouracil is an anti-cancer drug. It binds to the thymidylate synthase, and it inhibits the DNA synthesis pathway. That is the main thing that you have to know in this question. So if folinic acid leucovorin is added, it donates a reduced folate cofactor, which forms a highly stable ternary complex. That is 5-fluorouracil, thymidylate synthase, and folate cofactor. They form a complex, and it locks the enzyme completely. So synergistic and irreversible inhibition of DNA synthesis in cancer cells occur. That's why we administer leucovorin or folinic acid with 5-fluorouracil. But folinic acid also used as a SQ agent to protect normal cells in case of methotrexate therapy. That is different mechanism. Here it is different. Let's move to the next question. Question number 9. Folic acid is now included in the NIPI program. So NIPI stands for National Iron Plus Initiative. It is an initiative by the government of India which combines iron with folic acid across various age groups to tackle widespread dual deficiencies. Dual deficiencies in iron and folic acid. So who are the target population? Pregnant women, children, adolescents. Why pregnant women? It prevents macrocytic anemia and strictly prevents neural tube defects. For example, spina bifida in the fetus. In children, supports rapid growth phases and prevents nutritional megaloblastic anemia. In adolescents, corrects nutritional deficits during the pubertal growth spurt and prepares girls for future safe pregnancies. So that's why it is included. Then question number 10. E-poietin has little use in primary bone marrow disease and nutritional anemia. So e-poietin is a recombinant erythropoietin. It acts purely as a stimulator. It just tells the bone marrow to make more red blood cells. It tells the bone marrow that now you make more red blood cells. But imagine the bone marrow is a factory. If the factory has like a power outage, if there is no power supply in the factory, then it will not be able to produce red blood cells. And imagine it is a factory. The factory requires raw materials, right? If there is a curd factory, so it requires raw materials for making curd, like milk and other raw materials it requires. So what happens in primary bone marrow disease? In primary bone marrow disease, the factory is broken. Okay, there is no power supply, and in nutritional anemia, there is no raw materials. So even if you administer e-poietin, there will be no. It will be of no use. So in case of nutritional anemia and primary bone marrow disease, it is of no use or little use. So when it is useful, e-poietin is primarily reserved for chronic kidney disease when the bone marrow nutrients are normal, but the kidney is failing to produce endogenous erythropoietin. Then it is useful. Question number 11. Antacids reduce absorption of oral iron. So here also you have to know how iron is absorbed. Just for this question, know that iron is absorbed in ferrous state, that is Fe2+, in the duodenum. And the acidic environment of the stomach, that is hydrochloric acid, is essential to keep to keep iron in the soluble and absorbable ferrous state and prevent it from oxidizing into the non-absorbable ferric state. So what happens when you take antacid? If antacids are taken, it neutralizes the gastric pH and raises it neutralizes the gastric HCl and raises the pH. This makes the stomach alkaline and neutral environment, promotes oxidation of ferrous iron to ferric iron. This ferric iron forms insoluble complexes and fails to absorb across the duodenal mucosa. So if it's not absorbed, there will be decreased iron bioavailability. Bioavailability will be decreased. So that's why antacids reduce absorption of oral iron. Let's move to the next question. Question number 12. Oral iron is ineffective in patients on long-term proton pump inhibitors. This question and the previous question has the same answer. Long-term proton pump inhibitors cause profound and long-lasting acid suppression, achlorhydria. Gastric acid is absolutely essential to release the iron from food and to reduce the non-absorbable ferric form to absorbable ferrous form. Without acid, it can't happen. The same answer. And then parenteral iron is indicated in chronic kidney disease patient. I just told you that in chronic kidney disease patient, recombinant erythropoietin is administered. But why parenteral iron is indicated? So, in case of chronic kidney disease patient, they receive E14 injections. So bone marrow goes into overdrive, massive erythropoiesis. The factory is producing massive amount of RBCs. So for producing massive amounts of RBCs, you need more raw materials. So for making more curd, you need more milk. But that's why. The oral iron absorption is too slow. Cannot keep up with marrow demand. Functional. So there is functional iron deficiency. You need for making more curd, you need more milk. But if you are bringing the milk to the factory in a very slow vehicle, there will be functional iron deficiency, right? You have to bring the milk faster. That's why E14 becomes ineffective. That's why we administer parenteral iron to bypass the gut and directly supply the marrow in a fast vehicle. Understood? Then move to the next question, and this is last question. Heme iron is better absorbed than inorganic iron. Heme iron found in meat is absorbed as an intact porphyrin ring through its own specialized transporter. The name of the transporter is heme carrier protein 1. It does not need gastric acid. I just told you that this inorganic iron needs gastric acid for absorption, but it does not require gastric acid for absorption, and nor it is bothered by dietary inhibitors like phytates or tannins in tea that block these dietary inhibitors block inorganic iron. So that's why heme iron is better absorbed than inorganic iron. Oral bioavailability of heme iron is very high, up to 30%, and inorganic iron is very low, 1 to 5%.